Cultural competence by healthcare professionals is a concern as well. Cultural competence is the ability to interact effectively with people of different cultures. Culture is a term that goes beyond just race or ethnicity. It can also refer to such characteristics as age, gender, sexual orientation, disability, religion, income level, education, geographical location, or profession. Cultural competence means to be respectful and responsive to the health beliefs and practices, including the cultural and linguistic needs of a diverse population. Healthcare professionals may also have challenges regarding linguistic competence. These challenges arise due to some populations having low literacy skills, some having disabilities, as well as the communication issues that arise from explaining medical and healthcare issues. If there is a failure to communicate in a culturally or linguistically competent manner, then people may feel disrespected and fail to seek further medical attention when it's needed. Another serious concern regarding unequal health outcomes for non-whites is the issue of environmental racism. Environmental racism is a term used to describe environmental injustice within a racialized context. Environmental racism refers to socially marginalized racial minority communities which are subjected to disproportionate exposure of pollutants or the denial of access to sources of ecological benefits, meaning things like clean air, water, and natural resources. This is linked to class in that low-income families are more likely to live in areas where the environment threatens their health. When neighborhoods have toxic dumping sites or landfills or industry and refineries that are polluting the environment, then that impacts the residents' health. Poor families are more likely to live in homes that have been painted with lead paint as well, and small children can be exposed to lead poisoning that way. For various groups of non-whites, there are specific healthcare concerns. For Latinos and African Americans over the age of 65, this group is significantly less likely than whites to receive preventative care such as vaccinations. Undocumented workers are particularly at risk due to the harsh conditions of their work environments and the hazardous types of duties they have on the job. Extreme weather conditions are often part of agricultural work, and many other jobs involve the use of dangerous equipment. The instability of work and the manner in which day laborers are paid allows employers to deny health insurance to their workers. The African American community is more likely to have babies born with low birth weight. These babies are more than twice as likely to suffer from low birth weights. Weathering occurs when a person's health reflects the cumulative impact of his or her experience from conception to current age. Even before children are born, the environment in which their mother is carrying them can have an impact on the child, as can the stress that mother is enduring. Environmental stressors such as noise, overcrowding, hunger, violence, illness, housing, or food insecurity can be transmitted to the fetus. This can lead to the early onset of illnesses as early as in one's 20s. Native Americans have lower life expectancies, in part due to alcoholism and diabetes. However, these are not the only illnesses that have a higher rate in the Native American population. The American Indian and Alaskan Natives people have long experienced lower health status when compared with other Americans. Lower life expectancy and the disproportionate disease burden exists perhaps because of inadequate education, disproportionate poverty, discrimination in the delivery of health services, and cultural differences. These are broad quality of life issues rooted in economic adversity and poor social conditions. American Indians and Alaskan Natives continue to die at higher rates than other Americans in many categories, including chronic liver disease, cirrhosis, diabetes mellitus, unintentional injuries, assault and homicide, intentional self-harm and suicide, and chronic respiratory diseases. Asian Americans have a higher risk of contracting hepatitis B and certain cancers, and Asian Americans are the only racial or ethnic group to encounter cancer as the leading cause of death. Worldwide, 1 in 10 Asians is chronically infected with hepatitis B, and without treatment, 1 in 4 of those infected will die from liver cancer or liver failure. Liver cancer, 80% of which is induced by hepatitis B, is the second most common cause of cancer deaths in Asian American men. Pacific Islanders in particular have the highest rate of liver cancer of any American ethnic group. Cancer disparities are thought to reflect the interplay of socioeconomic factors, culture, diet, stress, the environment, and biology. Members of minority racial ethnic groups in the United States are more likely to be poor and medically underserved than whites, and limited access to quality health care is a major contributor to disparities. For example, regardless of their racial or ethnic background, the poor and medically underserved are less likely to have recommended cancer screening tests than those who are medically well-served. They are also more likely to be diagnosed with late-stage cancer that might have been treated more effectively if diagnosed earlier. Current policy recommendations for reducing health inequities call for changes in payment structures so that more low-income individuals can access early intervention, diagnostic and preventative care, as well as primary care. Improvements can be made through the use of culturally competent service providers and practitioners, which implicates the need for cultural competency training for all healthcare providers.